Hi, I'm Dr. Sianko, and this is my video on post-ICU syndrome. So being a health psychologist, I see many people who really experience a lot of difficult times being a patient. Being critically ill can be physically and emotionally an overwhelming experience. So I thought it would be a good idea to explain a little bit about post-ICU syndrome, which is also now referred to as medical PTSD. Because, well, not all patients end up in ICU, but the struggles and experiences can be very similar. So just to clear up, some people might have heard of the term ICU psychosis, and that's not what I'm talking about. That's actually a really quite outdated name that was kind of used for a hyperactive delirium. And I will be discussing delirium a little bit later, as that is one of the symptoms that can occur in post-ICU syndrome. So the next couple of slides, I'm just going to be talking about some of the common experiences people experience after being in an intensive care unit or critically ill. So obviously being quite weak, if you are quite unwell and spend a lot of time lying down, you're going to lose a bit of muscle mass. So when you do start moving, you're going to feel quite weak and fatigued. And you also might have some different physical sensations in your body as well. And numbness is a common experience that it can occur with people. And because of this kind of fatigue and muscle weakness, it's really common to feel out of breath, even when just kind of walking around or getting up to the bed to move to the chair. People also tend to feel quite self-conscious. They might notice that there's changes in how their hair, skin, and fingernails look. And this could be from the medical conditions or just being unwell from the medication and a few different factors. There's also a lot of changes to the body if there's surgery performed. Sometimes when patients can feel really self-conscious about having a trachea scar and also having a hoarse voice, especially if they've had a breathing tube. So a lot of the speech pathologists can help patients get their voice back, but some people will experience long-term changes to their voice. Other changes are mental changes. So how people think, their concentration, their memory. So a lot of people talk about having a bit of a foggy brain. Emotional changes also are common. So people might be feeling irritable, depressed, anxious, having lots of worries, especially about if they're going to get sick again or that they won't ever get back to where they were before. Some people even worry for their mental health, especially if they might have been having some hallucinations, like a delirium experience when they're in hospital. We'll talk about that a little bit more in a minute. So this slide, I'm just defining what post-traumatic stress disorder is, or PTSD for short. So a lot of people are aware of what PTSD is, more in the context of soldiers returning from war. I think the old name was shell shock for this condition. But really, it can be any traumatic event, from anything from witnessing a bank robbery to surviving the Black Saturday bushfires. And you can also see how it could also be in the context of a medical illness. So we know that a lot of people will have trauma symptoms after they experience danger, where their life or their body, serious injury, was at risk. PTSD can also occur to people who witness traumatic events as well. So it might be watching other people go through injury or death, and that can occur in the context of hospitals as well. Here is a couple of events that can be traumatic for people who are in hospital. So moments where you believe that you're going to die. So especially if you're coming into ED and you can't breathe very well, you're going to feel like that you might die. Having frightening, invasive, or painful medical experiences. Again, I've seen that in quite a few patients who might be having a bone marrow transplant or a big abdominal surgery, receiving bad news, and all the thoughts and feelings that goes along with that. Especially in the context of COVID, I'm seeing some of these patients who are receiving bad news all on their own, which is quite traumatic for many people. Another trauma event is hallucinations, and this can be caused from medications, delirium, or other illnesses. And they're probably a little bit more common than some people think. Experiences where you might be feeling powerless and haven't been helped. And again, it's just something that I definitely see on the hospital wards where patients might not know which doctor to talk to because there's so many consulting in, or they might be buzzing for a nurse, they're stuck on the commode and they're having to wait for a while because nurses are busy with other patients. And that can make people really hit home at how vulnerable they really are, which is a very unpleasant experience. Other traumatic events are being aware of other people dying. So people do die in hospitals, and people might be aware that we do call codes, and so doctors can get there quickly. Patients in shared rooms can understand that there's somebody who's really sick right near them, or that they're passing away, and that can be a really traumatic experience. So this slide shows some really common experiences that people feel during a traumatic event. And this can be any kind of traumatic event. So this includes a number of feelings such as anxiety and feeling terrified, humiliated, angry. But also it can be some kind of cognitive feelings such as feeling numb or confused, or having thoughts about being helpless, or bad things will happen, or even, kind of flash forwards where you can kind of see something happening. I know sometimes that happens in my mind. It can get pretty creative. I nearly had an accident the other day in my car, and my mind kind of played the whole event out. But fortunately, that is not what happened. But again, it can just show you how good our mind is trying to protect us. But then it's going to create a lot of these kind of experiences. So re-experiencing the trauma is really common for people with PTSD. And this can be factual memories. So, being, recalling that scenario of when you've told that, you've got a bad medical condition, and how scary that felt with that experience. Memories of a hallucinated event can also occur. So sometimes when people are a bit delirious or might be hallucinating because of a medication reaction, those memories that were laid down during that hallucinated event can resurface, and that can be scary. Memories of thoughts. So that's another one. So patients in intensive care might be thinking about how they're not being helped, and maybe even persecuted. And so that memory might come back of that thought. And a lot of these kind of memories are unwanted and kind of just pop into your mind. And these can be triggered by just, thinking, maybe daydreaming, but also watching TV, like a hospital drama, or, getting a text message about an upcoming medical appointment. Avoidance of thoughts, feelings, and reminders of the experience. So again, this is very common in all types of PTSD. So you might know people who've been in a car accident and they won't go down that same road anymore because it's very triggering of memories and experiences. So that's also very common in medical PTSD. So people might avoid seeing their medical doctors or going to a hospital or watching TV programs about hospitals. And even, touching parts of their own body. I had a patient who was very traumatized by a lot of the poking and prodding that he received, a lot of abdominal surgeries. And he got to the point that just anybody touching his stomach was really quite triggering for him. Changes in thoughts or mood. So some people will have frightening hallucinations, as I said before, and then they might think that they've actually got a serious mental health problem because of these kind of frightening hallucinations. Others might think they've been mistreated, and that they might even still believe that occurred, even though it might be a memory of a hallucination. After having a critical illness, a lot of people worry about getting sick again. We've even got a term for it, especially in the area of cancer, and it's called scanxiety. So a lot of people, have that 6-month, 12-month, 2-year follow-up scan and worry that their cancer will come back. And obviously nobody wants that. And so after going through a traumatic experience like that, they are going to worry about it. And having these beliefs, of course, can definitely lead to people feeling anxious or depressed. Lastly, people tend to feel on guard and on the edge. So fight-flight response. So when you're in that and you're stuck in that, you're going to find it really hard to relax. It's going to be a lot easier to be irritable and angry at the slightest things, and feeling anxious all the time, or most of the time. So how common is PTSD? Well, we know that it is a pretty normal experience to have symptoms after a trauma. And, in that first month, it's called more of an acute stress reaction. And that does make sense. However, if it persists for longer than a month, then we're tending to think about it being a post-traumatic stress disorder. And that can, depending on the trauma, be about 20 to 30% of people. After having intensive care, PTSD is expected to be about 1 in 5 people. So it's quite common, and one of the reasons why I'm doing this video, and knowing about the amount of people who are kind of going through ICU at the moment due to COVID, I thought it was very timely to do this video. So how does intensive care cause PTSD? Well, we know that if you need intensive care, you're really critically ill. You're at the most poorly you've ever been and the closest to death. So to keep people alive when they're critically unwell, they need round-the-clock monitoring and can go through quite a number of invasive medical procedures to keep them alive. There's going to be many machines. So here's a picture of just some of the common machines that are used to support people through a critical illness. And a lot of these machines are going to have alarms and alerts and loud noises to try and help staff monitor their patients. Patients are also going to have several tubes as well that can be helping them get nutrition and oxygen, and actually help also remove waste as well. And a lot of times ICU patients are going to be sedated. And again, in the context of COVID, when we have to put people on evasive ventilation, we do need to sedate them quite a lot, just so the body can relax enough to let the machines breathe for them. So sedation can be, especially coming out of sedation, can be quite scary for people. And even those who might not be completely unconscious, because again, it can be risky sedating people, we might need to restrain their arms and legs just so they don't kind of pull the tubes out. So this slide and the next one is just a couple more reasons why intensive care can cause PTSD. So medical interventions, again, frightening, uncomfortable, painful. Awareness that your life is in danger, and that's that talking about that threat system, that fight flight, which will lead to feelings of fear and terror. Prolonged duration. So yeah, the longer the trauma is, the harder or the bigger the dose of trauma. And again, in the context of COVID, people are spending a lot more longer in intensive care. Usually people might only spend a couple of days before being moved to the ward, but now we're seeing people in intensive care more for 5-6 days to maybe weeks. Delirium, which I'll talk about a bit later, but you can't think clearly, and that can be scary for a lot of people in its own right. Hallucinations, which I've talked a little bit before, and that could be experiencing things that are just not real, like bugs on the ceiling, or that you're being kidnapped by aliens. I've got some other examples in a minute. Sedation, so drifting in and out of consciousness, especially when we're not sedating people too heavy. But then again, also the sedative medication can lead to delirium. Mechanical ventilation, so being fitted with breathing tubes. So you've got like your non-invasive ventilation, which is quite a tight mask over your face, and yeah, it's pushing oxygen in, but it can actually mean that you can't communicate so well. And then you've got the more invasive ventilation, which might be intubation, and you'll be sedated for that. But again, you're not communicating if you're sedated. Restraint. Again, as I said before, sometimes we do have to restrain people just so they don't pull the tubes out. But waking up restrained can also be a traumatic event. Sleep deprivation, and that could be across the whole wards. Hospitals aren't a quiet place for rest and relaxation as people might think they are, but also being in pain, not breathing very well can cause difficulty sleeping. So again, we definitely know that sleep deprivation is a big part of our mental health. Environmental factors, which I've kind of just touched on just now, about lighting and noise that you have in hospitals. COVID-19, as I've been talking about, the impacts on the hospital, for patients who might not even be in hospital for COVID-19, but if you do have COVID-19, you're definitely not having any contact with your loved ones. You are isolated from them, and that is also can be quite traumatic, especially if you're really scared and worried that you might die. So staff, well, we have to wear full PPE now to try and protect our own health, but that means that we don't get to kind of show our face, and we show a lot of empathy and emotions through our face, and we have to wear masks. We can't do that as well. And also, it's harder to recognize people when you don't see their face. And when you kind of combine this with being semi-conscious or delirious, masked faces can definitely contribute to paranoia, like you've been kidnapped and things like that. Dave's story. So I'm going to share a story about Dave to kind of give a little bit of a context of what can happen to people who are coming into hospital and how medical PTSD can affect them. So Dave is a 60-year-old man who suffers from chronic obstructive pulmonary disease, COPD for short, and he also has a heart condition. He was really critically ill after an operation and wasn't recovering as he expected to. He had been having difficulty with breathing, and he needed to get more support and be given oxygen. When he was moved to the respiratory ward, he spent 5 hours of being extremely short of breath, and he described it as having to fight for every breath. Eventually, his doctors decided that Dave needed to be transferred to intensive care. By this point, he was exhausted and sure that he was going to die. As he was transported to the intensive care unit, there was a delay in the elevators, and he really remembers thinking that he is going to die in the elevator. Dave ended up spending 4 days in the intensive care unit. He was mechanically ventilated until his condition became stable enough for him to move back to the respiratory ward. He was able to recover enough to leave hospital after another week. When he returned home, Dave started having repeated nightmares and flashbacks of a coffin lid being put on him. He found these terrifying and would avoid going to sleep in an attempt to not have them. He would often spend all night on the couch in front of the television. The flashbacks brought up memories that Dave couldn't make sense of, and which made him feel even more anxious. He felt that he couldn't cope, and he started to avoid things that bothered him, such as lifts and hospitals. This was particularly problematic for Dave because he needed to attend regular hospital appointments for his COPD and heart condition. When he started psychological therapy many months later, Dave initially reported not being aware of much of his stay in the intensive care unit. He knew from his wife that he had stayed for 4 days, had been mechanically ventilated, and had also been restrained. He did not know much more because his wife became so upset when he asked her about it. During therapy, Dave learned that he was experiencing symptoms of PTSD. His therapist explained that his avoidance of things that reminded him of his experience in hospital was understandable, but actually might hinder his recovery. In therapy, his therapist asked him to replay his ICU memories slowly and carefully. Dave remembered an occasion in ICU when he was sure that he had died and a coffin lid had been put on him. He says he understands that the nails were actually details in the ceiling above him that he had misinterpreted due to the delirium he was experiencing at the time. Later in therapy, an important part of Dave's treatment involved revisiting the hospital where he had been treated. Accompanied by a nurse, he and his therapist retraced Dave's journey from the operating theatre to the respiratory ward to the intensive care unit, including a trip to the elevator that had malfunctioned. He found it anxiety-provoking to confront his fears, but with encouragement, he was able to expose himself to the things he was afraid of. He became aware from the knowledge that he had survived. He started to go to hospital appointments again, and gradually his fear reduced and he started to feel confident again. As he recovered, he recognised that his wife had also developed symptoms of PTSD, and he supported her to seek treatment. Delirium, as you've heard me mention a few times already in this video, is that many patients do experience delirium, especially those who are critically ill and are in intensive care. So delirium is a severe state of confusion. So people can see and hear things that are not there. They can feel confused and unable to think clearly. Thus, that will affect their understanding of what's going on. And that confusion can cause really strong feelings such as being frightened or lonely, and they might even feel persecuted or believe in unusual things. So a lot of people, not surprisingly, will worry that having delirium is a sign that they're going crazy or are mentally ill. But delirium is actually, as I said, very common. Between 4 and 9 out of every 10 patients in intensive care can become delirious. And this can rise to 8 out of 10 patients who need the support of breathing machines. So some of the risk factors for delirium is decreased oxygen to the brain, chemical changes in the brain, medications and anesthetic or sedation, as I've mentioned, having a severe infection, like a severe UTI, can cause delirium, severe pain, reduced eyesight and hearing, and having an older age. If you had experiences of seeing or believing unusual things when you were in ICU, the chances are high that that was a result of delirium. Fortunately, delirium is temporary and passes once the underlying cause is treated. If you are continuing to have experiences like the ones you had in hospital, it is likely that these are PTSD flashbacks of the hallucinations that you had in hospital, and not a sign that the delirium is continuing. So, recovering from PTSD. Although PTSD is extremely distressing to suffer from, it is a very treatable condition. And really, the first step is to understand how PTSD can cause people to be stuck and why it doesn't just get better itself. So, psychologists have developed a very helpful way, many helpful ways, I should say, to help people to think about their PTSD and put the pieces together so they can live a life they want to and not be trapped by avoidance and fear of bad things happening to them. So it's really good to actually have education around PTSD as part of the process of recovery. So we know that PTSD develops when our threat system, our fight-flight response, is active and stays active. So I've talked about that in my mind, body, stress video. And we know that this alarm, is really automatic and sensitive to triggers. And that's really potentially a good thing. As we said, a false alarm is better than missing a real one. But that can then lead to our system being over alert. So it's just seeing danger signals everywhere. And when you're in this fight flight response, it is going to be really difficult to sleep, relax, digest, form relationships, all of that other stuff. So our threat system is stuck on, and we're going to be feeling a lot of anxiety and tension. Another thing to really understand is that memories for trauma are different to normal memories. So these are 4 ways in which our memories are different to our normal memories. Immediacy. So these memories play out in our mind as if they're really happening. It's like reliving the trauma right there and there. And you can really lose track of actually where you are and what you're doing. And these memories are vivid. That's why they kind of, get stuck in them as if they're really happening, because they feel really real. You might hear sounds and smell smells, and really takes you back to that traumatic event. These memories are involuntary. You don't feel like you have any control over them, and they just pop into your mind unexpectedly. And they're fragmented. So your mind's really just going to be playing over the worst parts. It is not your fault if you experience memories like these. Your memories are this way because of your neurobiology, the way that your brain is designed. Psychologists think that trauma memories like these are stored differently in the brain. And an important task during trauma therapy is to kind of process these memories so they are less distressing. PTSD is about meaning making, and this is how we start the recovery process. So there's a number of different cognitive behavioral therapies that we can use, and they all work around our thoughts and beliefs, the cognitive, and also using behavior to actually help manage the feelings that go along with it. So PTSD is distressing, but we can learn to reinterpret those sensations and experiences and make them more accurate, so we can learn to manage them and not get caught up in them because they are unhelpful and not really responding to a true threat. Helping Tanya. So during her time in ICU, Tanya was delirious and thought she had been kidnapped by people who were planning to do her harm. When she was discharged from hospital, Tanya had many unwanted memories of things that she experienced in ICU. She had memories of conversations she thought she had overheard, and she felt the same feelings of terror that she had felt at the time. When these memories played in her mind, it felt like she was back in the ICU. They were so strong that she could smell things again, the smell of cleaning chemicals, and she could hear the beeps of machines. When she re-experienced these odd memories. It made her doubt what was real and what wasn't. While she was in intensive care, Tanya was very ill and had to be restrained to stop her from pulling out her tubes. Her delirium meant that she hallucinated that the nurses were ninjas. The meaning that Tanya's delirious brain made of this experience at the time was that she was being held captive and persecuted, and she was frightened as a result. After she was discharged from hospital, Tanya had nightmares and flashbacks which replayed this trauma. These felt so real, and her interpretation of these experiences was what made her think she was going mad, which made her feel even more frightened. So this slide shows how psychologists can help people process their traumatic events and the feelings associated with it. So we can look at the event and then how it was interpreted and then the feeling that comes from that. So being in ICU and realizing that she couldn't move, her interpretation is I'm being held captive, which of course will lead to people feeling frightened. And then the nightmares of having ninja nurses, her interpretation of that is I'm going mad, which again, of course, will make people feel frightened. So when people are having unhelpful interpretations of events, that can lead people to being stuck. So this is why psychological treatments for PTSD are really important to help people to kind of update or reprogram their unhelpful meanings of their trauma. And that's what I was talking about before with that meaning making. So on the next table here is unhelpful meanings and helpful meanings. So Tanya could clearly articulate what her unhelpful meanings were, like I'm being held captive by masked ninjas, to realizing what was actually really happening. I was being cared for in hospital by nurses wearing masks. Another unhelpful meaning, I'm going to die, my life is in danger. So again, just orientating to her to the here and now, saying yes, her life was in danger, but she's currently safe and recovering now. Nobody's listening to me, nobody cares. Helpful meaning, I couldn't speak because I had a tube in my windpipe. I was being cared for and people care for me now. So I won't read all the rest, but you can have a little look at those. But you can see what's actually happening here. We're seeing what the unhelpful meaning was and how we can reinterpret that and make it more helpful. Sometimes the things we do to cope are counterproductive. And this is a very human thing of what we do. Avoidance is very common. You've seen some of my other videos on that. And that's why we know that avoidance might feel good in the short term, but long term it's going to be unhelpful and lead you to being stuck in the PTSD. So this is another table that shows a little bit about how avoidance of reminders or not talking about it or using drugs and alcohol can actually not actually help you in the long term and actually make things worse. But also, checking, scanning, so some hyperarousal there can also actually make us be more worried and create false alarms, because anxiety and stress can create bodily symptoms, as we know. This is why it's another good reason why seeing a psychologist is actually really helpful. So this slide is putting it all together, just showing you how the traumatic events are right at the top. So for Tanya, feeling very unwell and having hallucinations can lead to both intrusive memory symptoms and, negative and unpleasant thoughts and feelings. This then can contribute to a current sense of threat, feelings that you're going crazy and just they're unpleasant as well. And then that could link into some, unhelpful avoidant coping strategies, which just, again, maintain those intrusive memories and unpleasant thoughts and beliefs. So you can see how that kind of becomes a maintaining cycle in these events. Psychological treatments for PTSD. So there's a number of them. So we've got the cognitive behavioral therapies. It could just be a classic CBT, but there's also cognitive therapy for PTSD and cognitive processing therapy. There's also acceptance and commitment therapy, which is another type of CBT, and also eye movement desensitization and reprocessing. So all of these therapies have really good evidence base for treating trauma conditions. So they might all be a little bit different, but a lot of their specifics are the same. So all of these therapies do involve some exposure to the trauma memories, again, so you can process them, just like we did in some of those tables with Tanya. Meaning making as well, so understanding how to make sense of those experiences and kind of reorientate you to the here and now and what you know now. Learning different coping strategies, so overcoming avoidance, moving towards meeting your needs and your values, pleasant activity scheduling, a whole lot of behavioral techniques can come into that as well. A lot of those therapies use. So some helpful and practical strategies. So teaching patients that their physical illness and delirium and the medical environment does affect people psychologically, and it's not about going mad or something being wrong with you. It's a very common experience, and once we acknowledge it, then we can get the help that we need. Educating people about hallucinations and flashbacks and why they happen is really important. Writing a daily diary along the medical record. This has been some recommendations to nurses, especially for people who are in ICU for a long time, just so this can be handed to the patient so they can actually understand what might have actually happened to them during their ICU stay. Site visits can also be helpful for people, where they can, revisit the ICU and actually see, what it was like and see the helpful people. That's quite difficult now with COVID. People can't just kind of go into hospitals at the moment, but hopefully that will change in the near future, where things can go back to normal. And meeting the staff that cared for them, that can be a really helpful thing as well. So what should I do if I think somebody might have PTSD after a critical illness, or even yourself? This is a pretty basic kind of screening tool that can be used. So the first question for the 5 is, have you been admitted to critical care or intensive care? Been critically ill? Yes. Then you'll ask the next couple of questions. And you can see that's really kind of related to the symptoms of PTSD. So nightmares, trying not to think about it. So avoidance, being on guard, feeling numb and detached, or feeling guilty about it as well. So if you have answered 3 yes to 3 or more, then, you might be suffering from a post-traumatic stress disorder. And that's when it's recommended to maybe contact a mental health specialist, like a psychologist, for a full assessment. Seeking help. See a psychologist. Now, there's 2 ways to really see a psychologist in Australia. So one way is to go to your GP and get a mental health treatment plan. This enables you to see a psychologist currently up to 20 sessions and have a Medicare rebate. So there normally will be a bit of a gap fee there, but you'll have to talk to the psychologist or psychology clinic that you're seeing what the cost is. But yeah, getting a mental health treatment plan will actually help cover some of the cost. You can also see a psychologist without going to your GP. You can just contact the psychologist or the clinic directly. You just will have to pay the full fee, but there's no limit to how many times you can see them, I think, depending on their bookings and their schedule. So a good way to find a psychologist is the Australian Psychological Society website. So that's the link there, psychology.org.au, find a psychologist. Now, if you're not really ready to see a psychologist, or you're just kind of curious about some more understanding about mental health, we've got a really good government initiative called Head to Health. So it has a whole bunch of apps, online programs, online forums, and a phone service that can help with referrals and where to go for help if you need more. But if you're just wanting to get some information that's easy to access, head to health.gov.au is a really great place to start. Thanks for watching.